Welcome to the Deep Dive, the show where we take a stack of information and turn it into actionable insight, giving you that aha moment without the information overload. Imagine for a moment a child playing with an old, brightly painted toy, perhaps something passed down through generations, or maybe a family gathering for dinner, pouring a glass of water from a tap in an older home. What if I told you that in these seemingly innocent, everyday acts, a hidden danger could be lurking? A legacy of ancient industries, one of humanity's oldest known poisons, still posing a very real threat today. It's a surprising reality, isn't it? That some of the oldest diseases known to humankind aren't just historical footnotes. They persist, often in unexpected ways, silently impacting health.
That's absolutely right. We're diving into something profoundly impactful, yet often silently insidious: heavy metal intoxication. And while our bodies absolutely require certain metals like iron, which is fundamental for carrying oxygen and for life itself, there are others, like lead, arsenic, or mercury, that serve absolutely no useful biological purpose. In fact, they can be profoundly, devastatingly toxic, even at very low levels.
And when we say toxic, we're not just talking about feeling a bit unwell, are we? The core problem with these heavy metals is how they just wreak havoc inside us, right down to the cellular level. They interfere with essential cations, those positively charged ions our cells need for everything from nerve impulses to muscle contractions. They kind of gum up the works of crucial enzymes, making it impossible for our bodies to perform vital chemical reactions. This often leads to something called oxidative stress. You can think of it like rust forming on the internal machinery of your cells, causing damage. They even mess with our gene expression and disrupt cell signaling, leading to this cascade of problems that show up as widespread, multisystemic signs and symptoms throughout the body.
Precisely. The effects can be widespread and, frankly, devastating, affecting virtually every organ system. But thankfully, the scientific and medical communities have developed some really ingenious ways to combat this threat. And that brings us to these fascinating compounds we call chelators.
Yeah.
Derived from the Greek word for claw, these molecules are literally designed to bind onto these toxic metals, gripping them tightly, and then, crucially, facilitating their excretion from the body. They are, in essence, our therapeutic claws against these pervasive poisons.
Exactly. And that's our mission for this deep dive. We're not just skimming the surface here, we're taking a comprehensive, in-depth look at this critical area, moving beyond a basic understanding to really master the complexities of heavy metal toxicology and their treatments, just like the elite professionals in the field. And to illustrate just how vital this knowledge is, let me set the scene for a real-world scenario we'll unpack later. Imagine a quiet Sunday morning church social. 27 people gathered, sharing coffee, baked goods, sandwiches, pretty normal stuff. But then, within a surprisingly short window, just 15 to 60 minutes, 13 of them developed vomiting and severe abdominal discomfort. And it got worse. 7 of these individuals were hospitalized with ongoing gastrointestinal symptoms, low blood pressure hypotension, and a concerning condition doctors call Anine-Gap metabolic acidosis. Now, that's a mouthful, I know, but essentially it means their body's delicate chemical balance was dangerously out of whack, a major sign of something seriously wrong. So, what diagnoses should be considered in such a rapid onset severe situation?
What test would you, as an informed individual, suggest? And what therapy would be on the table? We'll revisit this fascinating and frankly pretty alarming case as we go deeper into the material. Okay, let's unpack this pervasive threat, starting with perhaps the most infamous toxic metal, lead. It's a substance humanity has grappled with for millennia.
That's right. Lead poisoning is, without exaggeration, one of the oldest occupational and environmental diseases known. Really ancient. Ancient civilizations, from the Romans who used lead in pipes and cooking vessels, to miners thousands of years ago, all encountered its dangers. Despite this ancient recognition of its hazards, lead continues to find widespread commercial application even today. It's kind of amazing, really. Think about it. The vast majority, over 90% of lead consumed in the U.S., goes into the production of storage batteries, the kind in your car. It's also in ammunition, various metal alloys, solder, certain types of glass, plastics, pigments, and ceramics. It's still used in quite a lot of things.
And here's a surprising source that many people might overlook: the very water we drink. Corrosion of lead plumbing in older buildings or supply lines can dramatically increase the lead concentration in tap water. It's a silent, almost invisible contaminant.
And beyond that, lead's exposure is truly ubiquitous in our environment, distributed by human activity into the air, water, and food. Thankfully, we've seen significant declines in lead exposure over the last 4 decades. That's largely due to public health triumphs like the elimination of lead as an additive in gasoline.
Right, leaded gas. That's gone.
Exactly. We've also seen diminished contact with lead-based paint in homes and lead solder in food cans. And legislation, like a U.S. law in 2011, further reduced the maximum permissible lead content of children's products to a very strict 100 parts per million.
That's certainly progress. But lead hasn't disappeared entirely, which is a key takeaway here. It surprisingly persists in some formulations of aviation gasoline for piston engine aircraft. And here's where it gets really interesting and unexpected, highlighting the hidden paths of exposure, certain folk medicines. Like the Mexican remedies Azarcan and Greta, or some Ayurvedic preparations, they still contain lead. Even cosmetics, such as kohl used in some African and Asian communities, can be a source of exposure for both children and adults.
Right. And despite these public health measures, the subtle danger of lead remains a considerable concern. We now have extensive evidence indicating that even low-level lead exposure levels that might not cause overt dramatic symptoms can have subtle subclinical adverse effects. In children, this often manifests as neurocognitive deficits, impacting their learning and development. In adults, it can contribute to serious issues like hypertension and cardiovascular disease. And crucially, lead serves absolutely no useful purpose in the human body, and no level of lead exposure has been shown to be without deleterious effects on the developing central nervous system. This concept of no safe level for a developing brain is incredibly important for prevention.
So if there's no safe level, how does this ancient hazard actually move through our bodies once it gets in? Let's talk pharmacokinetics, or how the body handles the substance.
Well, inorganic lead, the most common form we encounter, is slowly but consistently absorbed. The primary routes are the respiratory tract,
Okay.
where inhaling lead dust is the most common cause of industrial poisoning.
Right.
And the gastrointestinal tract, which is the main route for non-industrial exposure, like from contaminated water or food. Interestingly, it's poorly absorbed through intact skin.
And absorption rates differ significantly between age groups. Right? That seems critical for understanding childhood vulnerability.
Absolutely. Adults typically absorb about 10 to 15% of ingested lead, but young children, due to their faster metabolism and developing systems, can absorb up to 50% of an ingested amount.
Wow, 50%.
Yeah, making them far more susceptible. And several factors can increase this absorption rate, including a diet low in calcium, iron deficiency, or simply ingesting lead on an empty stomach.
So once absorbed, where does it go?
Approximately 99% of lead quickly binds to our red blood cells, with only about 1% remaining in the plasma. From there, it's distributed to soft tissues. That's your bone marrow, brain, kidney, liver, muscle, gonads. Eventually, it finds its way to the surface of bones and then gets incorporated into the bone matrix itself.
And that's critical because lead also readily crosses the placenta, posing a direct and significant hazard to a developing fetus as it can accumulate in their bones even before birth.
Exactly. The elimination of lead from the body is complex. It follows what we call a multi-compartment model. Lead in the blood and soft tissues has a half-life of about 1 to 2 months, meaning half of it is gone within that time. But in the skeleton, where it's deeply embedded, the half-life stretches to years, even decades.
Years or decades, that's a huge difference.
It is. Approximately 70% of the eliminated lead leaves through urine, with smaller amounts via bile, skin, hair, nails, sweat, and breast milk. But a significant portion, about half of the absorbed lead, gets incorporated into the skeleton, which then becomes the repository for over 90% of the body's total lead burden in most adults.
And this skeletal storage has profound long-term implications, doesn't it? Slow release from the bones can keep blood lead concentrations elevated for years, even decades, after the initial exposure has ceased.
That's correct. And conditions that cause high bone turnover, like hyperthyroidism or prolonged immobilization from injury, can actually trigger the release of stored lead, leading to frank or overt lead intoxication.
And here's another astonishing fact. Retained lead bullet fragments, especially those lodged in joint spaces or fluid-filled cavities, can cause lead poisoning symptoms years or even decades after the initial injury. It's like a ticking time bomb within the body that can release lead slowly over time.
It really is. And this deep understanding of how lead moves through the body has led to the development of sophisticated biokinetic models, such as those used by the U.S. Environmental Protection Agency and the Department of Defense. These tools are incredibly useful for public health officials in developing standards for permissible lead exposure, both in the workplace and in the general environment, to protect populations from this insidious threat.
So, we know how it gets in and where it goes. Now let's get into the nitty-gritty, the pharmacodynamics. How does lead actually cause harm?
Lead exerts its multisystemic toxic effects through several core mechanisms. It's like a wrench thrown into the delicate machinery of our cells. It inhibits critical enzymatic functions, making our biological processes grind to a halt. It interferes with essential cations like calcium, iron, and zinc, which are vital for cell communication and structure. It generates that destructive oxidative stress we mentioned earlier, essentially causing cellular rust.
Cellular rust. That's a good analogy.
Yeah, and it also alters gene expression, changing how our cells read their genetic instructions, disrupts cell signaling, preventing cells from communicating properly, and damages the integrity of cell membranes and intracellular organelles, which are like the tiny organs within our cells. It's a multi-pronged assault on our cellular machinery.
And on all these targets, the developing central nervous system of the fetus and young child is by far the most sensitive.
Right. By far. Epidemiologic studies are quite clear. Even very low blood lead concentrations, levels that were once considered acceptable, can lead to subtle but significant deficits in neurocognitive function in children. As we emphasize, there's no demonstrable threshold or no effect level for a child's brain, meaning any lead exposure carries risk. This is a critical insight for anyone concerned with public health and child development.
And it's not a linear relationship, which is truly fascinating and underscores the insidious nature of low-level exposure. The decrement in intelligence associated with an increase in blood lead from less than 1 ml SEDDL to 10 ml DDL, a range often considered low, causes a greater drop in IQ points than the loss seen from a change from 10 to 30 ml GGDL.
That's right. It means the most significant and arguably most preventable damage to a child's developing brain happens at very low levels, making early detection and prevention absolutely critical. Adults are generally less sensitive to lead central nervous system effects, but long-term exposure, even to relatively low levels, can still cause subclinical neurocognitive issues like difficulty with concentration or memory. At higher concentrations, you start seeing more noticeable behavioral and neurocognitive signs: irritability, fatigue, decreased libido, loss of appetite, sleep disturbance, impaired visual motor coordination, and slowed reaction time.
And headaches, joint pain, muscle pain too.
Yes. Headaches, arthralgias, and myalgias are common, though tremor is less frequent.
And then there's the terrifying lead encephalopathy.
Yes, which usually occurs at very high blood lead concentrations, over 100 milli-CGDL. This is a medical emergency, characterized by increased pressure within the skull, and can lead to uncoordinated movements, ataxia, stupor, coma, convulsions, and, tragically, death. Beyond acute effects, newer studies suggest lead exposure may even accelerate age-related cognitive decline in older adults. Experimental animal research, in particular, has linked developmental lead exposure, possibly through epigenetic mechanisms.
Changes in gene activity without changing the DNA sequence itself.
Exactly, linked to hallmarks of Alzheimer-type pathology in the aging brain.
Wow. What about outside the brain, like peripheral neuropathy?
Yes. Lead can also cause overt peripheral neuropathy, affecting nerves outside the brain and spinal cord. This typically appears after chronic high-dose exposure, think months to years of very high blood lead concentrations. This neuropathy is predominantly motor, meaning it affects movement, and often presents clinically as painless weakness of the extensors, particularly in the upper extremity, leading to that classic wrist drop. Even if overt symptoms aren't present, preclinical signs of lead-induced peripheral nerve dysfunction can often be detected through specialized electrodiagnostic testing.
Moving beyond the nervous system, let's talk about the blood. Lead can cause anemia, right?
It can. A condition where your blood lacks healthy red blood cells. This might appear as normocytic anemia, where the red blood cells are normal in size, or microcytic and hypochromic, meaning they're small and pale. Lead essentially interferes with heme synthesis, the vital process of making heme, which is the iron-containing component of hemoglobin.
The protein in red blood cells that carries oxygen.
Precisely. It does this by blocking the incorporation of iron into a precursor molecule and by inhibiting key enzymes necessary for the process.
Are there diagnostic markers for this?
Yes, within 2 to 8 weeks after a blood lead elevation, you can often detect increases in heme precursors, such as free erythrocyte protoporphyrin or its zinc chelate, zinc protoporphyrin, in whole blood. This is a useful, if somewhat delayed, indicator. Lead also contributes to anemia by increasing the fragility of red blood cell membranes and reducing red cell survival time, meaning they break down faster. In severe cases, frank hemolysis, the bursting of red blood cells, can occur.
And basophilic stippling.
Right. While not always present or specific, Basophilic stippling small, dark granules visible in red blood cells under a microscope can sometimes be a suggestive diagnostic clue resulting from lead's interference with an enzyme important for red cell maturation.
Okay, the kidneys are another major target. What happens there?
Chronic high-dose lead exposure can result in renal interstitial fibrosis and nephrosclerosis, essentially scarring and hardening of the kidneys, often with a latency period of years before overt symptoms appear. Furthermore, lead can alter uric acid excretion by the kidney, leading to recurrent bouts of gouty arthritis, a painful inflammatory condition. This condition was historically known as Saturnine gout, linking it directly to lead.
And acute effects.
In acute high-dose lead exposure, transient azotemia and accumulation of nitrogenous waste products in the blood can sometimes occur, possibly due to intrarenal vasoconstriction, a narrowing of blood vessels within the kidneys. Population studies have consistently documented an association between blood lead concentration and measures of renal function.
And does having other kidney issues make you more susceptible?
It seems so. Existing risk factors for kidney issues, such as hypertension and diabetes, may increase an individual's susceptibility to lead-induced renal dysfunction.
The reproductive organs aren't spared either, are they?
Unfortunately not. High-dose lead exposure is a recognized risk factor for stillbirth or spontaneous abortion. While studies on low-level lead exposure and outcomes like low birth weight or preterm delivery have had mixed results, one well-designed study found a significant increase in the odds of spontaneous abortion for every small increase in maternal blood lead within a common exposure range, around 520 mg/dL.
That's worrying. What about prenatal exposure?
Recent research has linked prenatal exposure to even low levels of lead to decrements in physical and cognitive development during the neonatal period and early childhood. In males, blood lead concentrations above a certain threshold, around 40 mg/dL, have been associated with diminished or aberrant sperm production, impacting fertility. These impacts highlight the widespread and often silent damage lead can inflict across generations.
Let's talk about the gastrointestinal tract. What are the symptoms there?
Moderate lead poisoning can cause loss of appetite, constipation, and less commonly diarrhea. But at high dosages, individuals can experience intermittent, severe colicky abdominal pain, what's known as lead colic.
Colic. Okay. What causes that?
The exact mechanism isn't fully understood, but it's believed to involve spasmodic contraction of the smooth muscles of the intestinal wall, likely mediated by alterations in nerve signals.
And those lead lines on the gums, are they still seen?
Ah, the gingival lead lines. A historically noted, though now relatively rare, diagnostic clue in heavily exposed individuals with poor dental hygiene. These are dark deposits of lead sulfide at the gum line, resulting from the reaction of circulating lead with sulfur ions released by microbial action. It's a fascinating, if grim, historical marker that clinicians used to look for.
And finally, the cardiovascular system. How does lead affect the heart and blood pressure?
There's a strong body of evidence indicating that lead exposure elevates blood pressure in both experimental animals and susceptible humans. The mechanism for this blood pressure-raising effect likely involves lead's interaction with calcium-mediated contraction of blood vessel muscles, generation of oxidative stress, and interference in nitric oxide signaling pathways, which are crucial for regulating blood vessel dilation.
So it's linked to high blood pressure in populations.
Yes. In populations with environmental or occupational lead exposure, blood lead concentration is consistently linked with increases in both systolic and diastolic blood pressure. Even more concerning, studies of middle-aged and elderly individuals have identified relatively low levels of lead exposure, even though sustained by the general population, as an independent risk factor for hypertension. Lead exposure has also been associated with a prolongation of the QTc interval on the electrocardiogram, which can be a marker for increased risk of certain heart arrhythmias.
This is a major public health concern then, especially thinking about past exposure levels.
Absolutely. Prospective cohort studies have linked chronic environmental lead exposure, with population blood lead concentrations common before the 1980s, to a significantly increased risk of cardiovascular mortality. While general population blood lead concentrations have since fallen considerably in many developed countries, exposure in this range persists in occupational settings worldwide, highlighting the ongoing threat.
Okay, moving to diagnosis. Let's break down the major forms of lead intoxication. First, inorganic lead poisoning.
Right. Acute inorganic lead poisoning is uncommon today. It usually results from massive industrial inhalation of lead oxide fumes or, in young children, from ingesting a large oral dose, perhaps from lead-based paint chips, contaminated food, or even toys. The onset of severe symptoms typically requires days to weeks of recurrent exposure and can manifest as encephalopathy, that brain disorder, or severe colic. You might also see hemolytic anemia or anemia with basophilic stippling if the exposure has been subacute, and elevated liver enzymes.
And diagnosis can be tricky because it mimics other things.
Exactly. Depending on the presentation, it's often been mistaken for appendicitis, peptic ulcer, or even infectious meningitis. A subacute presentation with headache, fatigue, intermittent abdominal cramps, muscle pain, and joint pain has frequently been mistaken for a flu-like viral illness.
Is there anything specific to look for?
A key diagnostic clue, if there's been recent ingestion of lead-containing paint chips, lasers, or pellets, is the presence of radiopacities visible on abdominal x-rays. Those are like dense spots showing up on the x-ray.
What about chronic lead intoxication? How does that present?
Chronic lead intoxication presents differently with multisystemic findings. Patients typically complain of loss of appetite, fatigue, general malaise, headaches, difficulty concentrating, irritability or depressed mood, general weakness, joint and muscle pain, and GI symptoms. Lead poisoning should be strongly suspected in any patient with a combination of headache, abdominal pain, and anemia that can't otherwise be explained. Less commonly, it might present with motor neuropathy, gout, or renal insufficiency.
And in children?
In children, chronic lead intoxication should be considered if there are neurocognitive deficits, growth retardation, or developmental delay. It's crucial to recognize that many adverse effects of lead, especially the public health significant ones like subtle neurodevelopmental deficits in children and hypertension in adults, are nonspecific and may not immediately prompt a diagnosis of lead poisoning. This is why a deep understanding is so vital.
So how do you confirm it definitively?
The best way to confirm lead intoxication is by measuring lead in whole blood. This test reflects the lead currently circulating in blood and soft tissues, although it's not a reliable marker of either recent onset or long-term cumulative exposure. However, most patients with lead-related disease do have blood lead concentrations higher than the normal range. For context, the average blood lead concentration in the USA in recent years has significantly declined, but any elevated level warrants investigation.
What about measuring lead in bone? Is that useful?
While primarily a research tool, the concentration of lead in bone, assessed by non-invasive X-ray fluorescence, can correlate with long-term cumulative exposure and is being investigated for its relationship to various lead-related disorders. Interestingly, a chelation challenge test, measuring lead excretion in urine after a single dose of a chelating agent, reflects soft tissue lead content and is rarely indicated in clinical practice, as it's not a reliable marker of long-term exposure or skeletal lead burden.
Okay, and a quick word on organelle lead poisoning.
Right. Organelle lead poisoning is very rare now, largely because tetraethyl and tetramethyl lead have been phased out worldwide as anti-knock additives in gasoline. However, organelle lead compounds are still used in some commercial processes and in ammunition primers and explosives. Because of their volatility or lipid solubility, organelle lead compounds are well absorbed through the respiratory tract or the skin.
And they target the brain.
Yes, they primarily target the central nervous system, causing dose-dependent effects that can range from neurocognitive deficits and insomnia to delirium, hallucinations, tremor, convulsions, and even death.
Given lead's pervasive nature, prevention must be a huge focus.
Absolutely. It's an ongoing global effort. In the home, the U.S. Consumer Product Safety Commission, CPSC, adopted major restrictions on residential house paint way back in 1977. However, even recently, a significant percentage of homes still have lead-based paint and associated hazards. The EPA's lead renovation, repair, and painting rule now mandates that companies disturbing lead-based paint in pre-1978 homes, childcare facilities, and preschools must be certified and follow lead-safe work practices. They even updated clearance standards for lead and dust in 2021, showing ongoing vigilance.
What about workplace exposure?
In the workplace, the U.S. Occupational Health and Safety Administration, OSHA, estimates over 1.6 million workers are potentially exposed to lead. While state and federal OSHA programs set permissible exposure levels and require medical surveillance, including blood lead monitoring, the current OSHA rules, dating back to the late 1970s, are widely considered outdated and no longer offer adequate protection.
That seems like a problem.
It is. More modern guidance exists, and OSHA itself issued an advance notice in 2022, signaling its intent to update these standards. It's a critical area needing modernizing to better protect workers.
And drinking water.
Drinking water is another significant pathway. Lead can enter tap water from service pipes, interior plumbing, fittings, or faucets, especially when the water is acidic or has low mineral content, which corrodes these materials. The EPA's lead and copper rule requires water systems to institute corrosion control and other measures if more than 10% of tap water samples exceed a lead action level. The Safe Drinking Water Act, amended in 2011, also sets limits on lead content in new plumbing materials for potable water, and the EPA announced augmented efforts in 2021 to inventory and remove lead service lines.
Children are obviously at special risk because they put things in their mouths.
Exactly. Their normal mouthing behavior puts them at risk. The CPSC has stepped in here too, promulgating rules that limit the amount of lead in children's products like toys, jewelry, and printed material. It's a massive undertaking, especially when you consider that global lead production has doubled over the past 2 decades, largely due to the growing demand for lead-acid storage batteries. Preventing lead poisoning from these multiple industrial, commercial, and environmental sources remains an active and urgent public health focus worldwide.
So when prevention fails or exposure happens, what's the treatment strategy?
The general approach for inorganic lead poisoning involves immediate termination of exposure, intensive supportive care, and judicious chelation therapy. If a patient presents with lead encephalopathy, that severe brain disorder, it's a medical emergency requiring aggressive supportive care. This includes corticosteroids and medications like mannitol to manage swelling in the brain, and anticonvulsants if seizures occur.
And if they swallowed something, like those paint chips?
Right. If abdominal X-rays show radiopacities, it suggests retained lead objects that need gastrointestinal decontamination. Maintaining adequate urine flow is crucial, but it's important to avoid overhydration.
What about the chelation itself? What drugs are used initially?
For initial chelation, the go-to is intravenous EDTA calcium disodium, or KATZUNG. It's typically administered by continuous infusion for up to 5 days. Some clinicians even advocate initiating treatment for lead encephalopathy with an intramuscular injection of dimercaprol, followed by concurrent administration of both dimercaprol and EDTA.
And after that initial phase?
After 5 days of parenteral chelation, oral treatment with succimer, another chelator, can be instituted for continued management. If KATZUNG isn't available, oral succimer can even be successfully given via a nasogastric tube for severe lead encephalopathy.
How do you know when to stop therapy?
The endpoint for chelation therapy is usually the resolution of symptoms or the return of the blood lead concentration to its pre-morbid range. However, for patients with chronic exposure, stopping chelation can sometimes be followed by an upward rebound in blood lead concentration as lead re-equilibrates from the bone stores back into the bloodstream. That lead stored in bones is slowly released.
And there's a significant controversy, especially regarding chelation for asymptomatic patients, right? People who have high levels but feel okay.
Yes, that's a tricky area. Most clinicians agree on chelation for symptomatic patients with elevated blood lead. However, the CDC since 1991 has recommended chelation for all children with blood lead concentrations of 45 mg/dL or greater. But here's the kicker. A randomized clinical trial of succimer in children with blood lead concentrations between 25 and 44 mg/dL found no benefit on neurocognitive function or long-term blood lead reduction.
No benefit. Wow, that complicates things.
It does. It highlights the complexity and ongoing research in this field. And critically, prophylactic use of chelating agents in the workplace should never be a substitute for actually reducing or preventing excessive exposure in the first place. Prevention is always key.
So what are the current management guidelines?
Management guidelines for elevated blood lead levels, whether in children or adults, demand a conscientious effort to identify and reduce all potential sources of future lead exposure. Many local, state, and national government agencies have lead poisoning prevention programs that can assist in case management and environmental remediation. Blood lead screening of family members or coworkers of a lead poisoning patient is often indicated to assess the scope of the exposure.
What level triggers concern now?
In 2012 and revised in 2021, the CDC defined elevated childhood blood lead as at or exceeding 3.5 mg/dL. That's the reference value now. And finding a level at or above that should prompt immediate clinical and environmental investigation.
And for workers? Those OSHA rules are outdated, you said.
Yes, OSHA's lead regulations from the late 1970s mandated worker removal from exposure for blood lead levels higher than 50-60 mg/dL. This is no longer considered protective enough. An expert panel in 2007 recommended that removal be initiated for a single blood lead level over 30 mg/dL, or when 2 successive blood lead levels measured over a 4-week interval are 20 mg/dL or greater. The longer-term goal really should be for workers to maintain blood lead levels below 10 millisieGDL, and for pregnant women to avoid any occupational exposure that would result in blood lead levels higher than 3.5 millisieGDL.
Okay. And what about treatment for organic lead poisoning?
For organic lead poisoning, which, as we discussed, is now very rare, the initial treatment focus is on decontaminating the skin and preventing further exposure. If seizures occur, appropriate anticonvulsants are necessary. Empiric chelation may also be attempted if high blood lead concentrations are present, although the efficacy is less clear than for inorganic forms.
All right, let's shift gears to another fascinating yet deeply toxic element, arsenic. It's naturally occurring in the Earth's crust and has a remarkably long and varied history. Commercial products, pharmaceuticals, and even deliberate poisoning.
Exactly. In modern commercial applications, arsenic is used in the manufacture of semiconductors, in wood preservatives for industrial uses like marine timbers or utility poles, in non-ferrous alloys, glass, and even as a turf herbicide called monosodium methane arsenate, or MSMA. Historically, its pharmaceutical use is quite intriguing. Fowler's solution, containing 1% potassium arsenite, was widely prescribed from the 18th to the mid-20th century for many conditions. And organic arsenicals, most notably arsphenamine for syphilis, famously Paul Ehrlich's magic bullet, were actually the very first pharmaceutical antimicrobials widely used until sulfonamides came along in the 1930s.
It's incredible to think of a poison being a magic bullet, isn't it?
It is. But today, arsenic trioxide has been reintroduced as an orphan drug, meaning it treats a rare disease for relapsed acute promyelocytic leukemia, and it's finding expanded use in experimental cancer treatment protocols. Another trivalent arsenical, mercury, is used for advanced African trypanosomiasis, or sleeping sickness. On a darker note, some organ arsenicals, like lewisite, were developed as chemical warfare agents in the early 20th century.
And environmentally, arsenic is a huge concern, particularly in groundwater.
Yes, absolutely. Groundwater in some regions, notably the Ganges Delta in India and Bangladesh, contains naturally high levels of arsenic from mineral deposits, recognized as one of the world's most pressing environmental health problems. There's also concern about arsenic migrating from coal combustion wastes or coal ash deposited in unlined landfills, potentially contaminating underlying groundwater.
Even in food.
Yes. The U.S. FDA has even proposed action levels for inorganic arsenic in apple juice and rice cereals, specifically to reduce dietary exposure, especially for young children, recognizing its pervasive nature.
And then there's arson gas, a seize. That sounds particularly nasty.
It is. This is an arsonous hydride with extremely potent hemolytic effects, meaning it devastates red blood cells. It's manufactured primarily for the semiconductor industry, but it can be accidentally generated when arsenic-containing ores or scrap gallium arsenide semiconductors come into contact with acidic solutions, a highly dangerous scenario that can happen in industrial accidents.
Okay, so how does arsenic move through the body? It's pharmacokinetics.
Well, soluble arsenic compounds are well absorbed through the respiratory and gastrointestinal tracts. While absorption through the skin is generally limited, it can be clinically significant after heavy exposure to concentrated arsenic reagents. Once absorbed, most inorganic arsenic undergoes methylation, primarily in the liver, transforming into monomethylarsenic acid, MMA, and dimethylarsenic acid, DMA, which are then excreted, along with any residual inorganic arsenic in the urine. This methylation process is the body's way of detoxifying it.
Is it excreted quickly?
Relatively. For chronic daily absorption of typical amounts of soluble inorganic arsenic, roughly 2/3 of the absorbed dose is excreted in the urine within 2 to 3 days. However, after massive ingestions, the elimination half-life can be significantly prolonged, meaning it stays in the body longer.
What about inhalation?
If someone inhales low-solubility arsenic compounds, it can result in prolonged retention in the lung, which may not be reflected by urinary arsenic excretion, making diagnosis tricky if you're only looking at urine. Arsenic also has a tendency to bind to sulfhydryl groups in keratinized tissue, meaning after exposure ceases and urine values normalize, hair, nails, and skin may still contain elevated levels.
But that can be confounded by external contamination.
Exactly. Arsenic contamination on the outside of hair or nails might be indistinguishable from that incorporated after internal absorption. Specialized segmental analysis can sometimes help differentiate this for forensic purposes, for example, to determine when someone was exposed by looking at different segments of hair growth.
Let's delve into the pharmacodynamics. How arsenic actually causes toxicity and carcinogenicity.
Arsenic compounds are believed to exert their toxic effects through several modes of action. Trivalent arsenic, a more reactive form, interferes with enzyme function by binding to crucial sulfhydryl groups, essentially shutting down cellular processes. Pentavalent arsenic, another form, can substitute for phosphate, disrupting energy production. Inorganic arsenic, or its metabolites, can also induce oxidative stress, creating damaging free radicals, alter gene expression, and interfere with cell signal transduction, preventing cells from communicating properly.
Is one form more toxic than another?
Generally, inorganic trivalent arsenic or arsenate is more acutely toxic than inorganic pentavalent arsenate, though the body can convert between the two forms. And interestingly, the trivalent form of the methylated metabolites are actually even more toxic than the inorganic parent compounds, highlighting the complexity of arsenic metabolism.
Does how well someone methylates it matter?
Yes, reduced efficiency in the body's methylation process has been associated with an increased risk of chronic adverse effects. This methylation process requires a key molecule called S-adenosine, SAM, and arsenic-associated disruptions in this one-carbon metabolism may even underlie some arsenic-induced epigenetic effects, like altered gene expression, without changing the underlying DNA.
And arsine gas, how does that work?
Arsine gas, as we mentioned, is particularly nasty. Once oxidized in the body, it exerts a potent hemolytic effect, meaning it directly attacks and destroys red blood cells by altering ion flux across their membranes. It also disrupts cellular respiration in other tissues, effectively suffocating cells.
And arsenic is a carcinogen.
Yes, a recognized human carcinogen strongly associated with cancer of the lung, skin, and bladder, and possibly the kidney and liver. What's chilling is that these cancers may appear years after exposure to doses not high enough to cause other acute or chronic effects. And unfortunately, tobacco smoking may even interact synergistically with arsenic, significantly increasing the risk of certain adverse health outcomes.
What about arsenic from seafood? Is that different?
Yes, that's an important distinction. Marine organisms can contain large amounts of a well-absorbed trimethylated organoarsenic called arsenobutane, as well as a variety of arsenosugars and arsenolipids. Arsenobutane is actually non-toxic when ingested by mammals and is excreted unchanged in the urine. Arsenosugars, however, are partially metabolized by the body. There are also thioarsenite compounds that may contribute to toxicity, but these are generally minor metabolites. This distinction is crucial for accurate diagnosis, as eating seafood can lead to false positives for toxic arsenic exposure if not accounted for.
Now on to the major forms of arsenic intoxication and how they're diagnosed. Let's start with acute inorganic arsenic poisoning.
Okay. Acute inorganic arsenic poisoning strikes quickly, usually within minutes to hours after exposure to high doses of soluble inorganic arsenic compounds. Initial gastrointestinal signs include severe nausea, vomiting, diarrhea, and abdominal pain.
And it can get much worse.
Much worse. In severe cases, a diffuse capillary leak combined with extensive gastrointestinal fluid loss can rapidly lead to hypotension, low blood pressure shock, and death. Cardiopulmonary toxicity, including congestive cardiomyopathy, pulmonary edema, and ventricular arrhythmias, especially with QTc prolongation on the electrocardiogram, which affects heart rhythm, can occur promptly or be delayed for several days. Pancytopenia, a reduction in all blood cell types, usually develops within 1 week, and basophilic stippling of erythrocytes may be present soon after.
What about neurological effects?
Central nervous system effects, such as delirium, encephalopathy, and coma, can occur within the first few days. A particularly debilitating later effect is an ascending sensoromotor peripheral neuropathy, which may begin to develop after a delay of 2 to 6 weeks. This neuropathy can ultimately involve proximal musculature and result in neuromuscular respiratory failure, potentially requiring mechanical ventilation.
Any long-term signs?
Months after an acute poisoning, transverse white striae, known as Aldrich-Mees lines, may even be visible in the nails, providing a retrospective clue.
So when should doctors suspect this?
Acute inorganic arsenic poisoning should always be considered in an individual presenting with the abrupt onset of gastroenteritis combined with hypotension and metabolic acidosis. Suspicion should be further heightened if these initial findings are followed by cardiac dysfunction, pancytopenia, and peripheral neuropathy.
And confirmation.
The diagnosis is confirmed by demonstrating elevated amounts of inorganic arsenic and its metabolites in the urine, typically in the range of several thousand micrograms in the first 2 to 3 days after acute symptomatic poisoning. Crucially, arsenic rapidly disappears from the blood, so blood arsenic levels are generally not useful for diagnostic purposes, except in patients who are not producing urine.
What's the treatment for acute poisoning?
Treatment is based on appropriate gut decontamination, intensive supportive care, and prompt chelation. The recommended chelators are Unithal, administered intravenously, or dimercaprol, given intramuscularly. Animal studies indicate that the efficacy of chelation is highest when administered within minutes to hours after arsenic exposure. Therefore, if diagnostic suspicion is high, treatment should not be delayed while waiting for laboratory confirmation, which can take days or weeks. Clinicians act on suspicion in these critical cases.
What about succimer?
Succimer has also shown effectiveness in animal models and has a higher therapeutic index than dimercaprol. However, because it's only available for oral administration in the United States, its use may not be advisable in the initial treatment of acute arsenic poisoning, especially when severe gastroenteritis and splanchnic edema swelling of the gut might limit its absorption.
Okay, let's move to chronic inorganic arsenic poisoning. What does that look like?
Chronic inorganic arsenic poisoning also results in multisystemic signs and symptoms, appearing after chronic absorption of more than 0.01 milligrams per kilogram per day, roughly 500 to 1,000 micrograms per day in adults. The time to symptom appearance varies. Common constitutional symptoms include fatigue, weight loss, and weakness, along with anemia, nonspecific gastrointestinal complaints, and a sensor-motor peripheral neuropathy that often presents as a stocking glove pattern of dysesthesia, meaning numbness and tingling in hands and feet.
Are there characteristic signs?
Yes, the skin changes are among the most characteristic effects, typically developing after years of exposure. These include a raindrop pattern of hyperpigmentation, darkened skin patches, and hyperkeratosis, which are thickened areas of skin, particularly on the hands and feet. Other effects can include peripheral vascular disease, affecting blood flow to limbs, and non-cirrhotic portal hypertension, affecting blood flow in the liver. Epidemiologic studies also suggest a possible link to hypertension, cardiovascular disease mortality, diabetes, chronic non-malignant respiratory disease, and adverse reproductive outcomes.
And cancer, of course.
And of course, the big one, cancer. Lung, skin, bladder, and possibly kidney and liver cancers may appear years after exposure to doses of arsenic that weren't even high enough to cause other acute or chronic effects. Some studies even suggest a synergistic interaction between tobacco smoking and arsenic in increasing certain health risks.
Arsenic is also used in chemotherapy.
Yes, it's worth noting that arsenic is used in cancer chemotherapy regimens, often at a daily dose for weeks to months. This has been associated with prolongation of the QT interval on the electrocardiogram and occasionally malignant ventricular arrhythmias like torsades de pointes, which are serious heart rhythm disturbances.
How is chronic poisoning diagnosed?
Diagnosing chronic arsenic poisoning requires integrating clinical findings with confirmation of exposure. In the general population, the urine concentration of inorganic arsenic and its primary metabolites, MMA and DMA, is typically very low, less than 20 millishuch/L. High urine levels associated with overt adverse effects may return to normal within days to weeks after exposure ceases.
And remember to avoid seafood before testing.
Absolutely critical point. Avoid seafood for at least 3 days before providing a urine sample, as marine organisms contain large amounts of non-toxic organoarsenic like arsenobutane or arsenosugars that can be metabolized to DMA, confounding results and leading to false positives for toxic exposure. The arsenic content of hair and nails, normally very low, can sometimes reveal past elevated exposure, but these results must be interpreted cautiously due to the potential for external contamination. Segmental analysis of hair or nails using sensitive methods can sometimes have forensic value for investigating the temporal pattern of arsenic poisoning.
What's the management for chronic poisoning? Is chelation helpful?
Management primarily consists of terminating the exposure and providing nonspecific supportive care. While empiric short-term oral chelation with Unithal or succimer may be considered for symptomatic individuals with elevated urine arsenic concentrations, it has no proven benefit beyond simply removing the individual from the source of exposure alone.
Interesting. So just stopping the exposure is the main thing.
That's the cornerstone. Interestingly, preliminary studies suggest that dietary supplementation with folate, which is a cofactor in arsenic methylation, might be valuable in arsenic-exposed individuals, particularly men who are also folate deficient, as it may help their bodies detoxify the arsenic more efficiently.
Finally, arson gas poisoning. How does that present?
Arson gas poisoning produces a very distinctive pattern of intoxication dominated by profound hemolytic effects, meaning severe destruction of red blood cells. After a latent period that can range from 2 to 24 hours post-inhalation, depending on the magnitude of exposure, massive intravascular hemolysis can occur.
What are the initial symptoms?
Initial symptoms often include general malaise, headache, shortness of breath, weakness, nausea, vomiting, abdominal pain, jaundice, yellowing of skin, and hemoglobinuria, hemoglobin in urine.
And the kidneys are hit hard.
Yes, a severe consequence is oliguric renal failure, which is a sharp decline in kidney function causing reduced urine output. This often appears within 1 to 3 days, resulting from hemoglobin deposition in the renal tubules, literally clogging the kidneys. In truly massive exposures, lethal effects on cellular respiration can occur even before renal failure has a chance to develop.
Is diagnosis easy?
While urinary arsenic levels will be elevated, they are seldom available to confirm the diagnosis during the critical period of illness, making clinical suspicion paramount.
And treatment. Does chelation work here?
The mainstay of therapy is intensive supportive care, including exchange transfusion, vigorous hydration, and, if acute renal failure occurs, hemodialysis to filter the blood. Unfortunately, currently available chelating agents have not been demonstrated to be of clinical value in arsenic poisoning, underscoring its unique and devastating mechanism of action, which is primarily hemolytic. Now let's turn our attention to mercury, the mesmerizing quicksilver, the only metal that is liquid under ordinary conditions. It has captivated scientific interest since antiquity, and its mining was recognized as hazardous very early on. As its industrial use exploded over the last 2 centuries, new forms of toxicity were identified, often linked to the various chemical transformations the metal undergoes.
And there's no more chilling example than the Minamata disaster. In the early 1950s, a mysterious epidemic of birth defects and neurologic disease struck the Japanese fishing village of Minamata. The culprit: methylmercury in contaminated seafood, directly traced to industrial discharges from a nearby factory into the bay. It's a stark reminder of mercury's devastating potential and how industrial pollution can have unforeseen, catastrophic public health consequences.
Absolutely. And beyond elemental mercury and alkyl mercury, which includes methylmercury, other key mercurials include inorganic mercury salts and aryl mercury compounds, each with a relatively unique pattern of clinical toxicity. Mercury is predominantly mined as mercury sulfide in cinnabar ore and then commercially converted into various chemical forms. Recycling plays a role in recovering mercury from products like fluorescent lighting, switches, barometers, and thermometers, as its use is gradually phased out. Recent key industrial and commercial applications include dental amalgam, still a significant use, and relays, sensors, and switches. It's also used in the electrolytic production of chlorine and caustic soda, and in the manufacture of bulbs, lamps, and lighting.
And the use in artisanal gold mining is a big problem globally.
A huge problem. The widespread use of elemental mercury in artisanal gold production in many developing countries is a significant global concern, often by individuals who are unaware of its profound dangers and the direct health risks to themselves and their communities.
What about other uses? Pharma, cosmetics.
While mercury's use in pharmaceuticals and biocides has substantially declined, it's still occasionally found in antiseptics, certain folk medicines, and even cosmetic skin lightening creams. Thimerosal, an organomercurial preservative that metabolizes to ethylmercury, has been removed from almost all vaccines where it was previously present due to public concern, though scientific consensus has largely debunked its link to autism.
And environmentally, fossil fuels, dental fillings.
Environmentally, the burning of fossil fuels continues to release mercury, contributing to the bioaccumulation of methylmercury in fish, which remains a concern in some regions. And while low-level exposure to mercury released from dental amalgam fillings does occur, systemic toxicity from this source has not been definitively established.
Have there been efforts to control mercury globally?
Yes, recognizing these widespread risks, global efforts have been initiated. The United States, for instance, banned the export of elemental mercury in 2013. More broadly, the International Minamata Convention on Mercury, signed by many countries since 2013, calls for a phase-out of mercury in numerous products and manufacturing processes. Beyond products, the convention requires actions to control and reduce mercury emissions from sources such as power plants, smelting operations, and waste incineration and disposal, a comprehensive effort to curb its global release.
Now let's explore mercury's pharmacokinetics, how it travels through the body. Does absorption vary?
Yes, considerably depending on its chemical form. Elemental mercury is highly volatile and readily absorbed from the lungs as a vapor, making it the primary source of occupational exposure. Interestingly, it's poorly absorbed from the intact gastrointestinal tract, so swallowing it is less dangerous than inhaling it. Organic short-chain alkyl mercury compounds are also volatile and harmful by both inhalation and ingestion.
What about skin absorption?
Percutaneous absorption through the skin of metallic mercury and inorganic mercury can be clinically significant following massive acute or long-term chronic exposure. Alkyl mercury compounds, in particular, appear to be well absorbed through the skin. There's a chilling case where acute contact with just a few drops of dimethyl mercury resulted in severe delayed lethality, underscoring its extreme danger.
Wow. Where does it go once absorbed?
Once absorbed, mercury is distributed to tissues within a few hours, with the highest concentration typically found in the kidney.
How's it eliminated?
Inorganic mercury is primarily excreted through urine and feces. Its excretion follows a multi-compartment model. Most is excreted within weeks to months, but a fraction can be retained in the kidneys and brain for years. After inhaling elemental mercury vapor, urinary mercury levels decline with a half-life of approximately 1 to 3 months. For most individuals without occupational exposure, urine mercury concentration is typically very low, often below the limit of detection in recent studies.
And methylmercury, the kind in fish.
Methylmercury, on the other hand, has a longer blood and whole body half-life of approximately 50 days. It undergoes biliary excretion and enterohepatic circulation, with more than 2/3 eventually excreted in the feces. The average total blood mercury concentration in the U.S. population in recent years is still detectable, with about 90% of that present as methylmercury, mostly from dietary sources.
Can hair or nails be tested?
Yes. Like lead and arsenic, mercury binds to sulfhydryl groups in keratinized tissue, so traces appear in hair and nails. Mercury in hair has actually served as a valid biomarker of methylmercury exposure over an interval of weeks to months in many epidemiologic studies, as hair grows and records exposure over time.
Let's delve into the major forms of mercury intoxication and their clinical effects. What's the core mechanism?
At its core, mercury interacts with sulfhydryl groups in the body, inhibiting enzymes and altering cell membranes. This is its fundamental mechanism of harm. The specific pattern of clinical intoxication depends heavily on the chemical form of the metal, as well as the route and severity of exposure.
What about acute exposure? Inhaling vapor versus swallowing salts.
For acute exposure, inhaling elemental mercury vapors can cause severe chemical pneumonitis and non-cardiogenic pulmonary edema, a serious lung condition where fluid builds up without heart failure. Acute gingivostomatitis, or inflammation of the gums and mouth, may also occur, and neurologic sequelae can follow. Acute ingestion of inorganic mercury salts, like mercuric chloride, can result in a corrosive, potentially life-threatening hemorrhagic gastroenteritis, followed within hours to days by acute tubular necrosis, a severe form of kidney damage, and oliguric renal failure, where kidney function rapidly declines.
And chronic poisoning from inhaling mercury vapor. That is a classic triad of symptoms.
Yes, the classic and distinctive triad: tremor, neuropsychiatric disturbance, and gingivostomatitis. The tremor typically begins as a fine intention tremor of the hands, meaning it's worse when trying to perform a task, but it can progress to involve the face and even involuntary, jerky movements of the limbs. The neuropsychiatric manifestations are broad, including memory loss, fatigue, insomnia, and anorexia. There's often an insidious change in mood, characterized by shyness, withdrawal, depression, along with explosive anger or blushing. A behavioral pattern historically referred to as erethism or Mad Hatter's disease.
Mad Hatter's disease.
Exactly. Recent studies suggest that even low-dose exposure can produce subclinical neurologic effects. Gingivostomatitis, sometimes accompanied by loosening of the teeth, can also be reported after high-dose exposure. While electrodiagnostic testing may detect evidence of peripheral nerve damage, overt peripheral neuropathy is rare.
What's acrodynia?
An uncommon idiosyncratic reaction to subacute or chronic mercury exposure, seen mainly in children, is acrodynia. This is characterized by painful erythema or redness of the extremities and may be associated with hypertension, profuse sweating, anorexia, insomnia, irritability or apathy, and a miliary rash, a widespread rash of tiny red bumps.
And skin creams can be a source.
Yes. Chronic exposure to inorganic mercury salts, sometimes via topical application in cosmetic skin lightening creams, has been linked to neurological symptoms and renal toxicity, and severe methylmercury intoxication from illicitly produced skin lightening creams has also been reported.
What about methylmercury intoxication specifically? Like from the fish?
Methylmercury intoxication primarily affects the central nervous system. It presents with facial and peripheral paresthesias, that's numbness or tingling ataxia, loss of coordination, hearing impairment, dysarthria, slurred speech, neuropsychiatric disturbance, and a progressive constriction of the visual fields, making it feel like you're looking through a tunnel.
And the symptoms can be delayed.
Yes. What's crucial to remember is that signs and symptoms of methylmercury intoxication may not appear until several weeks or even months after exposure begins, making diagnosis challenging.
And is bad for pregnancy.
Methylmercury is also a significant reproductive toxin. High-dose prenatal exposure can lead to severe intellectual disability and a cerebral palsy-like syndrome in offspring. Even low-level prenatal exposures have been associated with a risk of subtle neurodevelopmental deficits, and it's important to address the thimerosal debate again here. A 2004 report by the Institute of Medicine's Immunization Safety Review Committee concluded that available evidence favored rejection of a causal relation between thimerosal-containing vaccines and autism.
Right, the science didn't support the link.
Correct. Similarly, other investigations by or with the CDC did not support a causal association between early prenatal or postnatal exposure to mercury from thimerosal-containing vaccines and neuropsychological functioning later in childhood. This highlights how scientific research addresses public health concerns.
And then there's dimethylmercury.
Ah, yes. A rarely encountered but extraordinarily neurotoxic form of organomercury that can result in delayed lethality, even following exposure to minute quantities. It's truly one of the most dangerous forms of mercury, known for causing severe, irreversible neurological damage.
How is mercury poisoning diagnosed?
Diagnosing mercury intoxication involves integrating the patient's history and physical findings with confirmatory laboratory testing or other evidence of exposure. In individuals without occupational exposure, urine mercury concentration is typically very low, and whole blood mercury is generally also very low. For an initial diagnostic approach to suspected mercury intoxication, measuring both urine and whole blood mercury is advisable, as different forms of mercury are excreted differently.
What about prevention? Especially dietary advice regarding fish.
Yes, the FDA and EPA have specific advice to minimize the risk of developmental neurotoxicity from methylmercury, especially for vulnerable populations. Pregnant women, women who might become pregnant, nursing mothers, and young children are advised to avoid consumption of fish with high mercury levels, such as swordfish and king mackerel. They should also limit consumption of canned light tuna to 2 to 3 servings per week, or albacore tuna to 1 serving per week.
But they shouldn't avoid all fish.
No, definitely not. Otherwise, these groups should aim to consume 8-12 ounces of a variety of low-mercury fish per week, as fish are an important part of a healthy diet. It's about choosing wisely.
And treatment for acute mercury exposure.
For acute exposure, intensive supportive care is paramount. Prompt chelation with oral or intravenous unithiol, intramuscular dimercaprol, or oral succimer may be valuable in diminishing nephrotoxicity after acute overexposure to inorganic mercury salts. Vigorous hydration can help maintain urine output, but if acute renal failure ensues, days to weeks of hemodialysis or hemodiafiltration in conjunction with chelation may become necessary. Since the efficacy of chelation declines with time, treatment should not be delayed until the onset of serious complications.
What about treating chronic exposure?
For chronic exposure, unithiol and succimer have been shown to increase urine mercury excretion following acute or chronic elemental mercury inhalation. However, the impact of such treatment on clinical outcome in these chronic cases is currently unknown.
And here's a critical warning. Dimercaprol, right? It's bad for chronic mercury.
Absolutely critical. Dimercaprol has been shown to redistribute mercury to the central nervous system from other tissue sites. Since the brain is a key target organ for mercury toxicity, dimercaprol should absolutely not be used in the treatment of chronic exposure to elemental or organic mercury because it could make brain damage worse.
Okay, very important distinction. What about methylmercury treatment?
For methylmercury, limited data suggests that succimer, unithiol, and N-acetyl L-cysteine, or NAC, may enhance its body clearance.
Okay, we've just navigated the intricate world of toxic heavy metals, understanding their pervasive nature and devastating effects. Now let's turn our attention to the therapeutic solution. The pharmacology of chelators, those claws we mentioned earlier. This is where our mastery of the material really comes into play.
Exactly. Chelating agents are drugs specifically designed to prevent or reverse the toxic effects of a heavy metal on an enzyme or other cellular target, or crucially, to accelerate the elimination of the metal from the body. Their mechanism is quite elegant. They form a complex with the heavy metal, essentially rendering the metal unavailable for toxic interactions with the functional groups of enzymes, other proteins, and cell structures. They effectively neutralize the threat by tightly binding the metal.
Like a claw grabbing it.
Precisely. Chemically, chelating agents contain one or more coordinating atoms, usually oxygen, sulfur, or nitrogen, which donate a pair of electrons to a cationic metal ion to form one or more coordinate covalent bonds. Depending on the number of these bonds, the complex can be referred to as mono, bi, or polydentate. Imagine the concept of a hexadentate chelate, like the one formed by EDTA with lead, where the molecule wraps around the metal like a claw with 6 points of attachment, holding it firmly.
However, while these claws are powerful, there are important considerations and potential pitfalls that professionals must understand. One significant concern is metal redistribution, right?
Yes, that's a major one. The metal mobilizing effect of a therapeutic chelating agent may not only enhance a metal's excretion, which is the desired effect, but it can also redistribute some of that metal to other vital organs. For example, dimercaprol, which we discussed, has been shown to redistribute mercury and arsenic to the brain, even as it helps enhance their urinary excretion. This is why it's not used for chronic mercury poisoning, as it could worsen brain damage. Similarly, some chelating agents designed for cadmium can redistribute cadmium to the kidney, potentially increasing kidney toxicity and negating their therapeutic value entirely.
And they can also deplete essential minerals.
That's another crucial consideration. Some chelating agents may enhance the excretion of essential minerals our bodies need, such as zinc in the case of calcium EDTA and DTPA, or zinc and copper in the case of succimer. While no clinical significance of this effect has been definitively demonstrated in most cases, some animal data suggest the possibility of adverse developmental impact, particularly in children. Thus, if prolonged chelation is necessary during the prenatal period or early childhood, judicious supplementation of the diet with zinc might be considered to prevent deficiencies.
And effectiveness depends on where the metal is and how long it's been there.
Exactly. The longer a metal's half-life in a specific organ, meaning the longer it stays there, the less effectively it will be removed by chelation. For instance, with lead chelation using calcium EDTA or succimer, the metal is more effectively removed from soft tissues than from bone, where its incorporation into the bone matrix results in prolonged retention, making it harder to extract.
And timing of administration is key.
Absolutely crucial. In most cases, the capacity of chelating agents to prevent or reduce the adverse effects of toxic metals appears to be greatest when administered very soon after an acute metal exposure. While using them days to weeks after an acute exposure ends, or in the treatment of chronic metal intoxication, may still increase metal excretion, their capacity to mitigate the actual pathologic effect of the metal exposure may be reduced. Early intervention makes a significant difference in outcomes for patients.
So let's dig into the key chelating agents currently in use in the USA, starting with dimercaprol, also known as BAL. What's its story?
Its origin story is quite fascinating. It was developed in Great Britain during World War II as an antidote against poisoning by lewisite, an arsenic-containing chemical warfare agent. This is how it earned its name. British anti-lewisite, or BA.
BAL, okay.
Dimercaprol is an oily, colorless liquid with a very strong, distinctive odor. It's typically dispensed as a 10% solution in peanut oil because its aqueous solutions are unstable and oxidize readily. This means it must be administered by intramuscular injection, which is often painful.
How does it work? And what's it approved for?
In animal models, dimercaprol has been shown to prevent and reverse arsenic-induced inhibition of sulfhydryl-containing enzymes. And if given soon after exposure, it can protect against the lethal effects of inorganic and organic arsenicals. In humans, it increases the excretion of both arsenic and lead, and may offer therapeutic benefit in acute intoxication by arsenic, lead, and mercury. It's FDA approved as a single-agent treatment of acute poisoning by arsenic and inorganic mercury. For severe lead poisoning, it's approved when used in conjunction with edetate calcium disodium, or EDTA.
How is it handled by the body?
While human metabolism studies are limited, it appears to be readily absorbed intramuscularly, metabolized, and then excreted by the kidney within 4 to 8 hours. Animal models suggest it may also undergo biliary excretion, but the human details are uncertain.
But it has significant side effects and limitations.
It does. Dimercaprol is associated with a high incidence of adverse effects when used at therapeutic doses. These include hypertension, fast heart rate, nausea, vomiting, tearing, salivation, fever, especially in children, and pain at the injection site. It can also cause thrombocytopenia, a drop in platelet count, and increased prothrombin time, which might limit intramuscular injection due to the risk of bruising or bleeding. But here's the crucial limitation for professionals. Despite its protective effects in acutely intoxicated animals, dimercaprol may redistribute arsenic and mercury to the central nervous system.
Right, the brain redistribution issue again.
Exactly. Therefore, it is not advocated for the treatment of chronic poisoning with these metals, as it could potentially worsen brain damage. Water-soluble analogs, Unithiol and Succimer, have since emerged with higher therapeutic indices and have largely replaced dimercaprol in many settings due to their improved safety profile.
Next up is succimer, also known as DMSA. This is a water-soluble analog.
Yes, a water-soluble analog of dimercaprol, designed to be more tolerable. Like dimercaprol, animal studies show it prevents and reverses metal-induced inhibition of sulfhydryl-containing enzymes and protects against the acute lethal effects of arsenic. In humans, treatment with succimer increases urinary lead excretion and decreases blood lead concentration. It may also decrease the mercury content of the kidney, which is a key target organ for inorganic mercury salts.
And it's oral only in the U.S.
That's right. In the USA, succimer is formulated exclusively for oral use. Though intravenous formulations are used successfully elsewhere, it's absorbed rapidly but somewhat variably after oral administration, with peak blood levels occurring at approximately 3 hours. The drug binds in vivo to the amino acid cysteine to form 1.1 and 1.2 mixed disulfides, which may actually be the active chelating moieties. Experimental data also suggests that a transporter protein facilitates the renal excretion of mercury compounds bound to transformed succimer and Unithiol. The elimination half-time of transformed succimer is approximately 2 to 4 hours.
What's it approved for, the typical dose?
Succimer is currently FDA approved for the treatment of children with blood lead concentrations greater than 45 millipgdl, but it's also commonly used in adults. The typical dosage is 10 milli/kilogram orally 3 times a day.
How effective is it? Is it better than EDTA?
Oral succimer is comparable to parenteral EDTA in reducing blood lead concentration and has largely supplanted EDTA for outpatient treatment of patients who can absorb the oral drug. However, here's an important caveat. Despite succimer's demonstrated capacity to enhance lead elimination, its value in reversing established lead toxicity or otherwise improving therapeutic outcome has yet to be established by a placebo-controlled clinical trial.
So it gets the lid out, but we're not totally sure if it fixes the established damage.
That's a fair summary of the current uncertainty for established toxicity. There's an interesting point from a study in lead-exposed juvenile rats. High-dose succimer did reduce lead-induced neurocognitive impairment when given to animals with moderate and high-dose lead exposure. Conversely, when administered to a control group that was not lead-exposed, succimer was actually associated with a decrement in neurocognitive performance.
Wow. So using it when not needed could actually be harmful.
That study suggests it might be, highlighting the delicate balance of chelators and the need for judicious use. You don't want to use them if they're not truly needed. Nevertheless, based on its protective effects against arsenic in animals and its ability to mobilize mercury from the kidney, succimer is also used in the treatment of arsenic and mercury poisoning.
What about side effects? Is it well tolerated?
Generally, yes. Succimer has been generally well tolerated in clinical trials, which is a big plus, making it a preferred option. It has a negligible impact on the body's stores of essential minerals like calcium, iron, and magnesium. While it does induce a mild increase in the urinary excretion of zinc, and less consistently, copper, this effect on trace metal balance hasn't been associated with overt adverse effects, though its long-term impact on neurodevelopment remains uncertain. The most common side effects are mild gastrointestinal disturbances like anorexia, nausea, vomiting, and diarrhea, occurring in less than 10% of patients. Less common are rashes, sometimes requiring discontinuation, seen in less than 5% of patients. Mild reversible increases in liver enzymes have been noted, and isolated cases of mild to moderate neutropenia, a drop in a type of white blood cell, have been reported.
Okay, next we have edetate calcium disodium, commonly known as EDTA.
Right. This is an efficient chelator of many divalent and trivalent metals in vitro, meaning in a lab setting. But here's a critical safety note. To prevent potentially life-threatening depletion of calcium, treatment of metal intoxication must only be performed with the calcium disodium salt form of EDTA, not other forms of EDTA, which could dangerously strip the body of vital calcium.
So only the calcium disodium salt. Got it. How does it work? Can it be taken orally?
EDTA penetrates cell membranes relatively poorly, meaning it chelates extracellular metal ions much more effectively than intracellular ones. Its highly polar ionic character limits its oral absorption. Moreover, and this is crucial, oral administration of EDTA may actually increase lead absorption from the gut, making the problem worse.
Oh, wow. Okay, so IV only.
Exactly. Consequently, EDTA must always be administered by intravenous infusion. In patients with normal renal function, EDTA is rapidly excreted by glomerular filtration, with half of an injected dose appearing in the urine within just 1 hour. It mobilizes lead from soft tissues, causing a marked increase in urinary lead excretion and a corresponding decline in blood lead concentration. In patients with renal insufficiency, the excretion of the drug and its metal mobilizing effects may be delayed, requiring careful monitoring.
What's it primarily indicated for?
EDTA calcium disodium is indicated chiefly for the chelation of lead, but it may also be useful in poisoning by zinc, manganese, and certain heavy radionuclides, which are radioactive isotopes.
And there was something about cardiovascular use, but a different form.
Yes, a fascinating, albeit controversial, area. A randomized clinical trial of EDTA disodium, not EDTA calcium disodium, observed a significant decrease in cardiovascular events in a subgroup of diabetic patients who had a prior history of myocardial infarction. A follow-up trial in a larger cohort of post-MI diabetic subjects is currently underway, so this is an evolving area. But it's vital to remember the distinction between the calcium salt used for heavy metal poisoning and the disodium salt being studied for cardiovascular issues. They are not interchangeable.
Other contraindications? What about toxicity?
Because the drug and the mobilized metals are excreted via the urine, EDTA is relatively contraindicated in anuric patients, those who aren't producing urine, as the metals can't be cleared. In such instances, low doses of EDTA combined with high-flux hemodialysis or hemofiltration have been described, using artificial kidney machines to help. Kidney toxicity from EDTA has been reported, but in most cases it can be prevented by maintaining adequate urine flow, avoiding excessive doses, and limiting the treatment course to 5 or fewer consecutive days. EDTA may result in temporary zinc depletion, though its clinical significance is uncertain.
Are there related compounds?
Yes, analogs of EDTA, the calcium and zinc disodium salts of DTPA, are used for the removal or decorporation of certain radioactive isotopes like plutonium, americium, and curium, and were FDA approved for this in 2004.
And there's a major issue with availability and cost for calcium EDTA now.
Unfortunately, yes. A critical detail for healthcare access. While calcium EDTA is a generic drug, first introduced in the 1950s, the sole U.S. distributor of premixed ampoules for injection dramatically raised the average wholesale cost of a 5-ampoule package from approximately $950 to an astounding $27,000 in 2014.
$27,000?
Yes. Consequently, very few hospital pharmacies in the USA continue to stock premixed ampoules for emergency treatment of severe lead intoxication. As of late 2022, pharmaceutical ampoules of calcium EDTA have been entirely unavailable due to a nationwide drug shortage in the United States, highlighting a significant challenge in treating severe lead poisoning.
That's a huge problem. Okay, moving on to Unithiol, or DMPS, another dimercaprol agent.
Yes, another dimercaprol-chelating agent and a water-soluble analog of dimercaprol, offering a more modern alternative. It's been available in official formularies in Russia and other former Soviet countries since 1958, and in Germany since 1976. In the USA, it's been legally available from compounding pharmacies since 1999 and was included on a specific list of bulk substances for compounding in 2019. Unithiol can be administered both orally and intravenously.
How is it absorbed and eliminated?
Oral bioavailability of Unithiol is approximately 50%, with peak blood levels occurring in about 4 hours. Over 80% of an intravenous dose is excreted in the urine, mainly as its transformed compounds. The elimination half-time of total Unithiol, including the parent drug and its transformation products, is approximately 20 hours.
What metals does it work on?
Unithiol exhibits protective effects against the toxic action of mercury and arsenic in animal models, and it increases the excretion of mercury, arsenic, and lead in humans. Animal studies and a few case reports also suggest its usefulness in the treatment of poisoning by bismuth compounds, another heavy metal.
Does it have FDA approval in the U.S.? What's its main use case?
Unithiol has no FDA-approved indications in the U.S. However, experimental studies and its pharmacologic and pharmacodynamic profile suggest that intravenous Unithiol offers advantages over intramuscular dimercaprol or oral succimer in the initial treatment of severe acute poisoning by inorganic mercury or arsenic. In suggested clinical practice, aqueous preparations of Unithiol are usually administered every 4 hours by slow intravenous infusion over 20 minutes. If the patient's cardiovascular and gastrointestinal status stabilizes after a few days, it may be possible to switch to oral administration. Oral Unithiol may also be considered as an alternative to oral succimer in lead intoxication.
Any special uses, like for kidney failure?
Yes, intravenous Unithiol, in conjunction with high-flux hemodialysis or hemodiafiltration, may be particularly useful in the treatment of patients with anuric renal failure caused by mercury salts and bismuth, as it helps remove the metals when kidneys aren't working.
What about side effects for Unithiol?
In terms of toxicity, Unithiol has a low overall incidence of adverse effects, typically less than 4%. The most commonly reported are self-limited dermatologic reactions, such as drug rashes or hives. However, isolated cases of major allergic reactions, including severe skin conditions like Stevens-Johnson syndrome, have been reported. A key caution during administration. Rapid intravenous infusion may cause vasodilation and hypotension, so it should always be infused slowly over 15-20 minutes to prevent a sudden drop in blood pressure.
Our fifth chelating agent is penicillamine, or dimethylcysteine, related to penicillin.
Yes, it's a white, crystalline, water-soluble derivative of penicillin. The D-penicillamine isomer is preferred because it's less toxic than the L-isomer. It's readily absorbed from the gut and is resistant to metabolic degradation, meaning it stays in its active form for longer in the body.
What is it mainly used for?
Penicillamine is used chiefly for the treatment of poisoning with copper or to prevent copper accumulation, as is the case in Wilson disease, which is a genetic disorder causing copper overload. It's also occasionally used in the treatment of severe rheumatoid arthritis.
Was it used for lead or mercury?
Historically, yes. Its ability to increase the urinary excretion of lead and mercury led to its use in outpatient treatment for these metals. However, succimer, with its stronger metal mobilizing capacity and lower adverse effect profile, has generally replaced penicillamine for these purposes, as it's a safer and more effective option.
Because penicillamine has more side effects.
It does. Adverse effects have been seen in up to 1/3 of patients receiving penicillamine. Hypersensitivity reactions can include rash, itching, and drug fever, so it must be used with extreme caution, if at all, in patients with a history of penicillin allergy. Kidney toxicity, specifically proteinuria, has been reported, and protracted use of the drug may lead to renal insufficiency. Pancytopenia, a reduction in all blood cell types, has also been associated with prolonged drug intake. While pyridoxine deficiency, a vitamin B6 deficiency, is a common side effect of other forms of the drug, it's rarely seen with the D-isomer.
Okay, next we have diferoxamine. This one targets iron.
Correct. Isolated from a type of bacteria, Streptomyces pilosis. This chelator binds iron avidly, meaning very strongly, but binds essential trace metals poorly, which is a key advantage as it won't deplete other vital minerals. Importantly, while it competes for loosely bound iron in iron-carrying proteins like hemosiderin and ferritin, it fails to compete for biologically chelated iron, such as that found in our cells' energy factories and oxygen-carrying proteins.
So it targets the excess iron without messing with the necessary iron.
Precisely. This means it helps remove excess iron without interfering with essential biological processes. Consequently, it is the parenteral chelator of choice for iron poisoning.
Are there other uses?
Yes, deferoxamine also has some novel applications. A clinical trial investigating acute deferoxamine treatment in patients with spontaneous intracerebral hemorrhage observed a beneficial clinical outcome in a subgroup of patients with moderate-sized blood clots in the brain. The proposed mode of action is a reduction in brain iron overload resulting from hemoglobin breakdown from the blood clot. Deferoxamine, combined with hemodialysis, can also be useful in treating aluminum toxicity in renal failure.
How is it administered?
As for administration, deferoxamine is poorly absorbed orally and may actually increase iron absorption when given by this route, so it must always be administered intravenously. It's believed to be metabolized, though the exact pathways are unknown. The iron chelator complex is then excreted in the urine, often turning the urine an orange-red color, which can be a visual cue of its action for clinicians.
What are the potential side effects?
Rapid intravenous administration can result in hypotension or low blood pressure. Other adverse idiosyncratic responses include flushing, abdominal discomfort, and rash. Pulmonary complications such as acute respiratory distress syndrome, a severe lung injury, have been reported in some patients undergoing infusions longer than 24 hours. And for long-term therapy, used for iron overload conditions like thalassemia major, neurotoxicity, and increased susceptibility to certain infections have been described, highlighting the need for careful monitoring.
Now let's discuss the newer iron chelators. Deferoxamine and deferoprone. Let's start with deferoxamine.
Okay. Deferoxamine is a tridentate chelator with a high affinity for iron and a low affinity for other metals like zinc and copper. It's orally active and well absorbed, making it a convenient option. Once in the circulation, it binds iron, and the complex is then excreted in the bile.
What's it approved for?
Deferoxamine was approved by the FDA in 2005 for the oral treatment of iron overload caused by blood transfusions, a significant problem in the management of conditions like thalassemia and myelodysplastic syndrome, which require frequent transfusions.
Is it well tolerated?
long-term usage is generally well tolerated, with the most common adverse effects being mild to moderate gastrointestinal disturbances and skin rash. Monitoring of liver and renal function is advised because kidney and liver impairment and failure associated with the deferoxirox have been reported during treatment of older adults with certain blood disorders.
And deferoprone.
Deferoprone is a bidentate iron chelator primarily cleared via the kidney. It was approved by the FDA in 2011 as a second-line oral chelator for patients with transfusional iron overload due to thalassemia.
Any major concerns with deferoprone?
Yes, neutropenia, a drop in crucial white blood cells, has occurred in 5–10% of patients, with a granulocytosis, a severe form of neutropenia, in approximately 1%, so regular hematologic monitoring is strongly recommended.
How do these newer oral agents compare?
Both deferoprone and deferoxirox appear to have similar efficacy in the treatment of transfusion-dependent hemoglobinopathies that require long-term iron chelation. Magnetic resonance imaging, or MRI, is increasingly used to evaluate cardiac and hepatic iron burden and to guide iron chelation therapy, providing a precise look at where iron is accumulating in vital organs like the heart and liver.
Can they be used together?
Yes. Regimens that combine different iron chelating agents have also been used in cases where monotherapy yielded suboptimal results, demonstrating a flexible and tailored approach to managing iron overload, as one drug alone might not be sufficient.
Finally, we have Prussian blue, chemically known as ferric hexacyanophthalate. Isn't that a pigment?
It is. This is a hydrated crystalline compound where iron atoms are coordinated with cyanide groups in a cubic lattice structure. Interestingly, while it's been used as a dark blue commercial pigment for nearly 300 years, its potential usefulness as a pharmaceutical chelator was recognized only about 3 decades ago.
How does it work as a chelator? What does it bind?
Its mechanism is primarily through ion exchange and secondarily by mechanical trapping or adsorption. It has a high affinity for certain single-valence cations, particularly radioactive cesium and thallium, which is a rare but highly toxic heavy metal.
How is it used?
Used as an oral drug, insoluble Prussian blue undergoes minimal gastrointestinal absorption, less than 1%, meaning it largely stays in the gut. The complexes it forms with cesium or thallium are non-absorbable, so oral administration diminishes intestinal absorption or interrupts enterohepatic and enteroenteric circulation of these cations, thereby accelerating their elimination in the feces.
So it helps get cesium and thallium out faster.
Exactly. Clinical case series show it significantly reduces the biologic half-life, or in vivo retention, of radioactive cesium and thallium, helping the body get rid of them faster.
What's it approved for?
Prussian blue was approved by the FDA in 2003 for the treatment of contamination with radioactive cesium-137 and intoxication with thallium salts. This approval was actually prompted by concerns over potential widespread human contamination from terrorist use of a radioactive dispersal device, often called a dirty bomb, making it a crucial component of the strategic national stockpile for public health emergencies.
That's fascinating. Is the pharmaceutical form different from the pigment?
Well, while soluble forms of Prussian blue may have better utility in thallium poisoning, only the insoluble form is currently available as a pharmaceutical in the U.S.
What's the dosage and monitoring? Any side effects?
After exposure to cesium-137 or thallium salts, the approved adult dosage of Prussian blue is 3 grams orally 3 times a day, with the corresponding pediatric dosage for children. Serial monitoring of urine and fecal radioactivity for cesium-137 and urinary thallium concentrations helps guide the recommended duration of therapy. Adjunctive supportive care for possible acute radiation illness or systemic thallium toxicity should also be instituted as needed. Thankfully, Prussian blue is not associated with significant adverse effects. Constipation, which may occur in some cases, should be treated with laxatives or increased dietary fiber.
We've covered a tremendous amount of ground, diving deep into the world of toxic heavy metals and their sophisticated countermeasures. Now let's circle back to our church social case study, where those 13 people became ill and 7 were hospitalized. It's time to apply our newfound expertise, just like a seasoned professional would.
Okay, let's do it. To recap, we had 27 people attending a church social, and within a rapid window of 15 to 60 minutes, 13 developed vomiting and abdominal discomfort, with 7 hospitalized for ongoing gastrointestinal symptoms, low blood pressure, and anion gap metabolic acidosis, that dangerous chemical imbalance in the blood.
Right.
So initial thoughts would naturally go to food poisoning, wouldn't they?
Absolutely. Bacterial food poisoning is the most common cause of gastrointestinal signs and symptoms appearing in a group after a common meal. Consumption of food contaminated with preformed bacterial toxins, like those from Staphylococcus or Bacillus cereus, can indeed cause vomiting after an incubation period as short as 1 to 2 hours. This is a common diagnosis that doctors would initially consider.
However, here's why this case was unusual and where a deeper understanding becomes critical. The rapid onset of vomiting in some individuals literally within 15 minutes. That's very fast.
Extremely fast. That rapid onset, plus the alarming progression to hypotension and metabolic acidosis, were not typical for common bacterial food poisoning. This specific constellation of symptoms, rapid onset, severe GI distress, cardiovascular compromise with low blood pressure, and a metabolic acidosis, is far more suggestive of intoxication by certain toxic chemicals or drugs, including inorganic arsenic and mercury salts, such as sodium arsenite or mercuric chloride.
So how did they narrow it down? Why not mercury?
Good question. In this specific case, the absence of hematemesis, which is vomiting blood, bloody diarrhea, or signs of acute renal insufficiency, significantly lowered the likelihood that inorganic mercury was responsible. That's a crucial piece of the puzzle, as these symptoms are more characteristic of mercury poisoning.
And the big reveal, what was it?
The big reveal. An epidemiologic investigation subsequently uncovered that all the affected individuals had consumed coffee that had been deliberately adulterated. This coffee contained a shocking 6,300 parts per million of inorganic arsenic.
Whoa, deliberate poisoning.
Yes, a truly deliberate act of poisoning that this deep dive knowledge helps us understand.
So how would you confirm this diagnosis and what treatment would be considered?
Well, analysis of urine for arsenic and mercury and stool and emesis for bacterial pathogens would be reasonable initial diagnostic tests. But here's the critical takeaway for medical professionals in such emergencies. Pending those test results, which can take time, prompt empiric treatment of this constellation of findings with the chelating agents unithiol, succimer, or dimercaprol would be entirely appropriate and potentially life-saving.
Right, you can't wait for definitive lab results when lives are at stake.
Exactly. This case perfectly illustrates the critical importance of having a deep understanding of toxicology, even for presentations that on the surface might seem like common bacterial food poisoning. It underscores the immense value of targeted, informed intervention in a medical emergency, turning a mysterious illness into a treatable condition because professionals understood the nuances of heavy metal poisoning. It's about connecting seemingly disparate symptoms to a singular critical underlying cause.
And that brings us to the end of our deep dive. We've journeyed from the ancient omnipresence of heavy metals, their subtle and devastating mechanisms of toxicity, all the way to the sophisticated claws of chelation therapy, designed to counteract their deadly effects.
The key takeaways from this journey are clear. Understand the insidious nature of even low-level exposures, grasp the multisystemic impact these toxins can have on the human body, and appreciate the nuanced pharmacology of the chelators. You've now mastered information that allows for a much deeper understanding of public health and medicine.
So if we connect this to the bigger picture, considering how deeply heavy metals are embedded in our industrial history and even our natural environment, what societal or environmental changes might slowly be releasing these stored toxins back into our lives, creating new, subtle health challenges we're only just beginning to grasp. Think about aging infrastructure, the changing climate, or even unexpected industrial shifts. It's something to ponder, isn't it?
It really is. This knowledge empowers you to look at your own environment, your daily life, and even broader public health issues with a new, informed perspective. We encourage you to continue that curiosity and proactive learning.
Until next time, keep digging deeper.